Hi everyone, my name is Roma Vasa and I'm a child and adolescent psychiatrist. I've been working at the Kennedy Krieger Institute for about 25 years now. The Kennedy Krieger Institute is a pediatric rehabilitation hospital, and I started working there in the general psychiatry clinic, and I started seeing a lot of kids with autism there. And over time, I was thinking, wow, I love working with children and families with autism spectrum disorder. This is an incredible group of individuals. They have many developmental, psychosocial, and psychiatric needs, and their families are exceptional in raising a child with a developmental disability. So I eventually moved over to the autism clinic, and so now I work in the Center for Autism and Related Disorders, and I have an outpatient clinic, and I see kids, adolescents, young adults who are on the spectrum in my clinic. I love working with this population, and probably one of the main reasons why is because autism spectrum disorder is a very heterogeneous condition. So there's an expression, if you've seen one child with autism, you've seen one child with autism. There are no two children, no two families who exhibit the same profile, the same struggles and challenges. And so this keeps me very interested. Even in the psychiatric realm, I'll see kids with ADHD, anxiety, and aggression, or I'll see kids with depression, self-injury. There are kids who are very verbal and fluent and really wanting to make friends, and others who are not able to speak and wanting to connect with the world. So the presentations are so varied. The second reason I love working in this field is because taking care of kids on the spectrum requires knowledge in many areas. So psychiatry, child development, family systems, legal and educational systems, medical pathology. So this really keeps me on my toes, and I love the interdisciplinary collaboration I have with colleagues. And finally, I have to say I love this field because the group of psychiatrists across the country that work with children and adolescents with autism, they are amazing. They are smart, passionate, committed, inviting, supportive, and when I come to the academy meetings, I just really enjoy connecting with them and talking with them, and it's been a great experience. So if anybody's interested in autism spectrum disorder, I'm happy to chat with you. Please email me. So now I'll go on to my talk. I'll be talking about co-occurring mental health conditions. These are conditions that I see in the clinic very regularly, and I'm going to be going through various aspects of these conditions, including their presentation, assessment, and phenotype. So starting with my disclosures, I get an honorarium from ACAP for speaking at the conference. I consult to the Autism Learning Health Network. I have a faculty appointment at the Johns Hopkins University School of Medicine, and I'm also a faculty member at the Kennedy Krieger Institute, and I get some funding there as well. So here are the objectives for this talk. First, I'm going to review the prevalence and impact of psychiatric disorders in kids on the spectrum. And I want you to keep in mind that I'm also going to include target psychiatric symptoms that might be transdiagnostic across disorders or don't neatly fit into disorders. Second, I'll talk about general principles of assessment of psychiatric conditions in autism. And there are two key points I want you to keep in mind when I go through assessment. One is to always tease out overlapping symptoms between autism and psychiatric disorders, and the second is that psychiatric conditions can manifest in the traditional DSM way in this population, but they can also manifest in atypical ways. So again, two key points I want you to take away from this objective. And the third is I'm going to review common mental health conditions seen in this population. There's a broad array of conditions. I'm going to cover the most common ones, the bread and butter conditions that you're likely to see in practice. I will brush upon treatment. If you're interested in learning more about treatments, I'm going to ask you to listen to Dr. Gwinnett's lecture on behavioral treatments and Dr. Lohr's lecture on psychopharmacology. So let's start with prevalence. So psychiatric disorders are extremely common in kids with autism spectrum disorder. In population-based samples, 70% of kids will present with one disorder, 40% with 2 disorders. Now, if you look at studies of clinical samples, like in the clinic that I work in, or maybe in the clinic that some of you work in an outpatient clinic, 95% of kids have 3 or more disorders. There's a higher rate of emotional and behavioral problems in this population compared to typical kids, and also compared to those with intellectual disability who do not have autism. And there's high rates of anxiety and depression in adults with ASD. So you can see that this is a population with a heavy burden of psychopathology, and the psychopathology is present across the lifespan. As child psychiatrists, we are perfectly suited and have a responsibility to treat these kids. So here are some of the psychiatric disorders that can manifest in this population. So you'll see the garden variety ones, ADHD and anxiety. The most research has been done on ADHD and anxiety, but also depression, some work on bipolar and OCD, emerging work on gender dysphoria, psychosis, and suicidality, and then psychiatric conditions such as irritability, aggression, self-injurious behaviors. These are very common. And then we see ODD-CD. There's been new interest in trauma, and less work, but definitely evolving interest in studying substance abuse disorders and eating disorders in this population. I'm going to cover mainly the conditions on the left side. And the one thing I want you to remember is that most of the research in this field has focused on kids who are verbal and cognitively able. So this population of kids with autism, kids who don't speak or have intellectual disability, so far they've been neglected in research studies. So what's the impact? Well, having a psychiatric disorder on top of the autism makes the autism symptoms worse. You're going to see more repetitive behaviors, more sensory issues, more social problems. It amplifies all the autism symptoms. Second, it interferes with all the autism treatments. So I will get calls from the speech pathologist. We're not able to move ahead with treatment because this child is very anxious. Or we can't do some work we really want to do in improving adaptive functioning because the child's having ADHD and can't organize and can't focus. These conditions impair educational and family functioning, and they complicate the transition planning to adulthood. So when we think about what next after leaving the school system, it's not the autism symptoms that are the most influencing factor, but it's the psychiatric presentations. And finally, these conditions have the potential to really spiral down into a psychiatric crisis. So kids with very severe explosive outbursts, kids who become suicidal, very self-injurious. We know that kids with ASD are much more likely to visit the ED than kids without ASD. There's higher rates of boarding in the ED. Many are just sitting there because there's no place to go. And there's higher rates of inpatient psychiatric hospitalization. So the impact is profound. Another reason to be very vigilant, very mindful of screening and treating. I want to call your attention to this recent review that's come out in 2018. This is a really thorough, comprehensive article that goes through all the psychiatric disorders in kids on the spectrum, discusses their prevalence, their phenotype, and their longitudinal course, and whatever other correlates we know about these conditions. So there's a lot of reviews out there, and I think there's many wonderful book chapters and reviews written. I'm presenting this one as the most recent one with the most current up-to-date research findings. So let's move on to psychopathology. So the first question to ask is, how are psychiatric disorders related to autism? Well, we're conceptualizing this in 3 ways. First, they might be a very separate and distinct true comorbidity. So they present in the same way they do as in kids without autism. So separation anxiety is exactly the same in a kid with autism as without. There's clinginess, there's distress at the sign of separation, difficulty sleeping alone. These are separate conditions. They have nothing to do with the core features of autism. Second, they might be better explained by autism. So if there's a kid who's been very extensively bullied at school, right, they're going to start having a lot of social anxiety, right? They're not going to want to approach people. They're going to want to avoid social situations. They might even verbalize, people don't like me, they reject me. Do we really want to give that child a diagnosis of social anxiety disorder? Maybe not. Maybe this is autism-related symptoms and social struggles leading to bullying, leading to psychiatric disorders. And third, some of these disorders that we typically see in the DSM, their presentation may be altered by the presence of autism. So I go back to anxiety again. Kids who are in social situations, they're very anxious, but they don't have the introspective awareness to know that, hey, other people are looking at me, judging me. And so when you assess for social anxiety, they're not going to report that fear of negative evaluation that's the hallmark of social phobia, but they're going to be anxious in social situations. So that just shows how the autism challenges modify the presentation of the psychiatric illness. So we're still learning more about these relationships, and they might be different for different conditions. And until we learn more about them, we use the term co-occurring to refer to the relationship between autism and psychopathology. So let's move on to assessment. So assessing for psychiatric disorders in kids with ASD is definitely more challenging than in the general population. And that's because of many ASD-related challenges and our lack of measures to assess these conditions. So I think keeping that in mind, it's going to take time, longitudinal assessment, commitment to rolling up your sleeves and really digging into these overlapping symptoms and atypical presentations to conduct a really comprehensive evaluation. And I think it's just important to brace yourselves for that this is going to be a process. I may not know the answer when the child walks out of my office. It may take me 2 or 3 visits to figure this out. So if we specifically go through what some of the diagnostic challenges are. So first, because of language and social impairments, self-report may be compromised or it may be non-existent. Second, kids on the spectrum, even those that are very verbal, they might have trouble identifying and describing their emotions, a term called alexithymia, which refers to this process. Third, all the measures that we use in the general population, they are not validated for the ASD population, right? So we might want to use Vanderbilt's, and if we do, we should use them carefully, but they haven't been validated for use in the spectrum. So we don't have many objective measures. Fourth, there can be overlapping symptoms between autism and psychiatric disorders that can lead to diagnostic overshadowing. So if we think symptoms such as anxiety, or social withdrawal or social indifference is part of the autism, we're not going to think it's a separate problem, and we're not going to be able to diagnose anxiety, and there's going to be a missed opportunity for treatment. Conversely, if we think social anxiety, if we think all the autism symptoms are reflective of social anxiety, so a parent coming in and saying, my child doesn't want to socialize, they have social anxiety. And if we overdiagnose social anxiety, we'll end up overtreating. So it's really important to tease out these overlapping symptoms. Next, we have to be prepared that these disorders may present differently than they do in the way they do in typical youth. And again, as I mentioned, the assessment can be time intensive. So let's go through some principles of assessment. First, think about having multiple raters and using multiple approaches. So have parents come in, think about whether the child can give you information, contacting teachers, therapists, and try to get different types of data. So what I like doing is asking parents to bring videos in. You know, if they're saying my child's having a lot of tantrums, can you bring in a video so I can see what this looks like? Or having parents ask teachers to actually send behavior charts in or descriptions of the child in the classroom. And definitely getting on the phone and talking to the therapist to see what they're observing in their sessions. Use a developmentally sensitive approach. So kids on the spectrum may not understand words like anxiety and worry or depression. I think we have to explain these in very simple terms, like do you feel scared? Sometimes general words like upset are preferable to more complex words. And we first need to understand the child's ASD symptoms and developmental level. So get a lay of the land. What does your child's autism look like? Understand their social motivation. Is this a child that wants to make friends or has no interest in friends? Does the child have repetitive behaviors? How often do they occur? Are transitions difficult? Do they have sensory issues? Get the baseline autism profile set. And then ask about language level. So when you get information about language level, you'll know how much can I use the self-report. And get a better understanding of cognitive functioning. Are you working with a child who has intellectual disability, borderline intellectual capacity, above average? This will, again, give you a better understanding of communication skills. Tease out overlapping symptoms, evaluate for DSM presentations and atypical symptoms. And then you ask, are the symptoms that I'm eliciting above and beyond what's expected of the child's developmental level and ASD challenges? So keep in mind that kids with ASD, they face many more challenges than kids without ASD on a daily basis, right? Sensory experiences are difficult, crowds, noises, smells, social interactions. This is a struggle. Unpredictability every day, right? Our worlds are chaotic, noisy, and unpredictable. This is hard for kids on the spectrum. So we have to give them some slack, that if they're having trouble with these things, it's okay. It doesn't mean it's a psychiatric disorder. It means that their autism symptoms are really challenging. Next, as with any psychiatric disorder, once you get a baseline and you're assessing for psychiatric symptoms, do these symptoms, are they a change in baseline functioning? Is the child different? Or is this more of the same? Or kind of baseline, had a slight blip in deterioration in functioning for 2 or 3 days, but back to normal. We want to know change in baseline and sustained. And can the symptoms be accounted for by other factors? So look for medical problems, which can present behaviorally, social and communication challenges. Sometimes the school expects more of the child than what the child is capable of doing. That can create behavioral issues, emotional difficulties, and then stressors at home. That can also cause psychiatric symptoms such as depression, anxiety, restlessness, sleep problems. And lastly, do the symptoms cause functional impairment? And this is a really important question to ask. And the way you want to ask it is you want to say, do these symptoms cause impairment above and beyond the impairment caused by autism, right? Because you're looking for that additional impairment from psychopathology. You don't want to capture the impairment of autism, otherwise you might be treating autism. So to recap, if you have to take home points, understand the developmental level, tease out overlapping symptoms, ask about DSM and atypical presentations, rule out other factors. Is there a change in baseline? Ask about impairment. Okay, so now I'm going to go on to common psychiatric conditions. So ADHD, very common. A lot of research has been done on this condition. Population-based studies suggest that about 30% of kids on the spectrum present with ADHD. In my clinic, probably 70%. So very common condition. All 3 types manifest combined, inattentive, hyperactive, impulsive. Probably we're seeing more of the combined presentation in this population. We think there's a lot of shared genetic and biological overlap between ADHD and autism. And so the risk for ADHD in kids with autism is high. And there's definitely many overlapping features. So kids with ASD can just be inattentive because they're distracted by their internal thoughts or their special interests or sensory experiences in the environment. They're also generally active, right? They can be hyper-aroused. They have difficulties with language, social skills, and executive dysfunction. So all these overlapping features here can be part of autism, and they can be part of ADHD. The key is when these get worse, could that mean that an additional diagnosis of ADHD should be considered? So first and foremost in the assessment of ADHD, rule out other factors that could be causing the ADHD, as I went through before: medical, psychosocial, communication, educational. Is the child distracted by external stimuli or engaged in their own thoughts and activities? And so if you give out a Vanderbilt and someone circles distractible, you want to be sure you're teasing out what type of inattention you're seeing. When asking about hyperactivity and impulsivity, ask about what the most dangerous behavior is. I've had kids climbing on counters, on top of fridges. They can be very, very active. And you want to know how unsafe this can be. And be very careful when using measures such as the Vanderbilt scale, which we all use, because the scales may not be measuring the same constructs in kids on the spectrum. So when evaluating, important to evaluate contextually. ADHD symptoms may reflect social challenges. So I go back to the Vanderbilts. Questions like, is easily distracted, does not listen when spoken to directly. If a teacher is seeing these behaviors in a social context, these may reflect more language and social than true inattention and hyperactivity. Symptoms must occur across all contexts. They must persist, and they must occur across social and non-social settings. Remember, ADHD is a disorder of sustained attention when engaging in non-preferred activities. So just touching upon treatment. First, we try psychosocial treatments, behavior management, educational supports. Important to refer for testing. Important to guide the parents in behavior management principles at home. And going back to safety, it's critical, especially if there's a hyperactive impulsive component. There is quite a bit of research on medications. We have the most of evidence for stimulant therapy with about a 50% efficacy in this population, although a higher rate of side effects. Okay, moving on to the next most common condition, anxiety, present in about 40% of kids on the spectrum. Possible risk factors, well, increased age and social functioning. And that's probably because most of the studies have been in kids who are cognitively and verbally able. But we are learning that kids who are more aware of their disability, want friends, want to be integrated, are more likely to experience anxiety because they start realizing they're different. And this is a major source of distress. Family history can also be a risk factor. The key to remember in anxiety assessment is ordinary daily experiences can be anxiety-provoking. Doesn't mean the person has an anxiety disorder. And going back to my two principles of overlapping symptoms and different phenotypes, look at the number of overlapping symptoms between anxiety and autism, repetitive behavior, rituals, poor eye contact, and social avoidance. Important to tease these out. So kids on the spectrum can exhibit typical DSM disorders. Social anxiety, I've had kids tell me, somebody's going to laugh at me. Generalized anxiety, kids can report worries. We just need to ask them, do you think about scary things again and again? Does it make you feel bad? They can have phobias. They can have separation anxiety. We also need to consider atypical presentations, and these are anxiety symptoms that are very connected to the autism. So I mentioned earlier social anxiety, but not able to report fear of negative evaluation. So they don't want to go into social settings, and it's not because of the sensory issues or the noises, or the noises and all. They just don't like being there, but they can't tell you why. Excessive anticipatory worry about schedules or environmental changes is anxiety. Intense worry about their special interests. So it's not about, oh, I want to, view my Dora video again and again and again. It's like, it's more anticipation. When can I see it? When can I see it? What if somebody takes my Dora doll? What if it breaks? What if it gets lost? What if somebody steals it? It's that constant anticipation about the focus that's above and beyond what you would expect in ASD. And then we see specific phobias. These are more idiosyncratic phobias. So a common phobia that I see is kids who are very scared of the happy birthday song. They don't want to go to social places because what if they hear a happy birthday song? Parents are saying, we can't go to restaurants in case it's somebody's birthday. Kids who are scared of people who have beards. In our clinic, I've seen kids who are scared of babies who are crying. These aren't the typical phobias of bugs and heights and all of that. These are more atypical. And so we're coding these atypical presentations as unspecified anxiety. We don't know how it relates to typical anxiety syndromes. We don't know how it relates to autism. But we are seeing that these types of atypical presentations of anxiety are quite prevalent and excessive. And here's a study of atypical anxiety in 59 kids, aged 7 to 17 years, with an IQ of higher than 60. And in this study, a specific anxiety measure was used to assess both DSM anxiety and atypical anxiety. And as you can see, 46% of kids endorsed ambiguous or atypical anxiety. This anticipatory anxiety about schedules, the unusual phobias, the social anxiety, and 48% endorsed our categorical syndromes. So the take home is ask about both. Go through the DSM and then start asking about the atypical symptoms. When assessing anxiety, first and foremost, am I going to be able to get information from the child? How valid is the self-report? And second, really important, is the parent observing anxiety, or is this what they're inferring is anxiety? And that's really important because you want to get parent observations. We know parents know their children best, but we want to guide them in helping them accurately identify what's anxiety and what's not. Is this a change of baseline? And what are for those kids who are not able to express anxiety, what are the observable manifestations? Clinginess, fearful affect, avoidance, more ASD symptoms, behavioral symptoms. Ask about these because an exacerbation of these symptoms could reflect anxiety. And then going back to the impairment. Does the anxiety cause impairment above and beyond what we see in autism? In terms of treatment, we've got a lot of good evidence from modified CBT for kids who are cognitively able, and this is going to be covered in Dr. Gwinnett's lecture. But this is exciting new research that's come out. Behavioral therapies for children who are challenged, environmental modifications, and addressing the sensory issues. In terms of medications, there are currently no SSRI trials for the treatment of anxiety and autism. We can consider treating individual symptoms like hyperarousal with alpha agonists or sleep problems. If we choose to use SSRIs, the recommendation is to start low and go slow. Okay, depression. Prevalence is roughly about up to 10% in children and adolescents, much higher. I mean, children and adolescents, we're seeing even higher rates in teens and adults. Again, just like anxiety, probably more common in those who are more socially motivated, have self-awareness of their differences. Family history is a risk factor, and there are overlapping symptoms: social withdrawal, constricted or flat affect, and sleep problems. If we go to the phenotype, think typical DSM symptoms, ask about everything: low mood, anhedonia, cognitive symptoms, hopelessness, worthlessness, suicidality, and change in neurovegetative symptoms. But this is how depression can present atypically: increased ASD symptoms, more constricted affect. Focus on special interests now with morbid themes, regression, and an increase in aggression and self-injury. So think of both presentations. And when assessing, first evaluate. Can this child tell me that life is not fun anymore, that their activities are not fun, that they experience sorrow and sadness? Assessing for the two different phenotypes, look for changes in baseline behavior, and ask about the stressors, most common being peer relations, social awareness, self-perception, and bullying, which is a common problem in kids with ASD in terms of being bullied, and conduct a suicide risk assessment, and I'll talk about suicide shortly. In terms of treatments, there are only 2 studies of modified CBT for children with ASD and depression, both with mixed results. And both are trying to get at addressing the social challenges that could be contributing to a depression, but more research is needed. And if we go to medications, again, there are no medication trials for depression in this population. We can follow the guidelines as indicated in typical youth, but careful with SSRIs, start low, go slow, think about behavioral activation. So those are probably the 3 more common disorders, and now I go to bipolar disorder, for which we have very little research on. The existing studies state that perhaps it occurs in about 2% of kids on the spectrum. In clinical samples, you're going to see a higher prevalence of 35%. Family history may confer risk. And just take a look at all the overlapping symptoms here. Kids with autism can be chatty. They can go approach people socially and want to talk to them. They can be very active, especially if they have ADHD. They can be irritable, have sleep problems. They can have high arousal from sensory experiences or emotion dysregulation. So there's a lot of overlap between bipolar and autism, and a lot of parents will come in saying, you know, I think my kid has bipolar, and they'll list all these symptoms. And I think you got to be really, really careful, because this is a disorder that can easily be overdiagnosed, and kids can easily get over-medicated. So in terms of the phenotype, we do see classic manic presentations: grandiosity, elation, irritability, sudden change in neurovegetative symptoms, racing thoughts, increased goal-directed activity. But we also see atypical presentations, so cyclical irritability, dysphoria, agitation, worsening aggression and self-injury, rapid, loud, nonstop talking, pressured speech, pacing, sudden decrease in sleep, and increased repetitive behaviors. So it's really important to assess very carefully, look for a change in baseline. A teenager who is very chatty, very social, goes up to people and talks with them nonstop, and has sleep problems, that person doesn't have bipolar disorder. That's their autism. They have some sleep problems, some sensory problems. They're indiscriminately a little bit too social. They talk a lot. But if that girl had a sudden change in baseline and started exhibiting aggressive behaviors, self-injurious behaviors, not sleeping, not eating, increased agitation, and we saw this in a cyclical pattern, that might suggest to you that there's a cyclical affective mood disorder present. In terms of treatment, there are no treatment studies for bipolar disorder with kids on the spectrum, and so the general recommendation that is to follow guidelines in typical children with close monitoring. Okay, OCD. Little data on prevalence. The studies that exist give you a very wide range, 8 to 30%, again, depending on if you're looking at a population-based sample or if you're looking at a clinic sample. So the common overlapping symptom here is repetitive behaviors. They're common to autism, they're common to OCD. And this is also another very common presenting concern. Parents coming in and saying, my child has OCD, and it's because of all the repetitive behaviors. And another common presenting concern is, my child is obsessed with trains. I think they have OCD. So the thing to remember is the over-focus on the special interest is not an obsession. That's part of the autism. And the presence of repetitive behaviors doesn't necessarily mean the child has OCD. So here's a table to help you tease out the phenotype of repetitive behaviors in autism versus compulsions that belong to OCD. So first is the valence. So kids with autism enjoy their repetitive behaviors. They enjoy rocking, they enjoy stimming. The compulsions of OCD are not very pleasurable. There's a very anxious arousal associated with them. Kids are upset if they're blocked. The topography is different. So in autism, the repetitive behaviors are more hand flapping, rocking, shaking fingers in front of the eyes, following routines, watching the same video again and again, lining up objects. OCD, we can see typical OCD symptoms in kids with ASD. And we think about the themes that we see in typical kids: contamination, aggression, hoarding, checking, washing, repeating, touching, and tapping. So be sure to distinguish these two topographies. In ASD, the repetitive behaviors are not preceded by obsessions. In OCD, they are, although it's very difficult to elicit those obsessions in kids on the spectrum. And the function of the behaviors is different in ASD. So in ASD, the repetitive behaviors are often to self-soothe or to satisfy other needs, such as sensory or wanting to access reinforcements. Or sometimes the repetitive behaviors increase in the setting of other psychiatric disorders. Whereas in OCD, the repetitive behaviors have some kind of neutralizing function. So I think if you can differentiate these two, you'll have a nice detailed way to tease out and help parents understand, hey, this is all these behaviors, these types of repetitive behaviors belong to autism. I would be concerned about OCD if I saw more of this phenotype of repetitive behavior. In terms of treatment, so there's a few studies of modified CBT showing promising results using exposure therapy, but clearly more work is needed. And again, going back to the medications, we don't have any evidence-based trials for the treatment of OCD in ASD. Keep in mind that if you see SSRI trials for kids on the spectrum, they're not for repetitive behavior. They're not necessarily for OCD. They're for repetitive behavior. So there's a large, multi-site, very well done citalopram study in kids on the spectrum. That study was for repetitive behaviors associated with autism, not OCD, and that study showed no group differences between those who received placebo versus med. Okay, so moving on to gender dysphoria. There's emerging research showing the co-occurrence of ASD and gender dysphoria, and I'm seeing some of this in my clinic. And I have seen it in individuals who are cognitively able and verbal, but I have also seen it in individuals with moderate intellectual disability. It is very hard to assess, though, because of the social communication challenges that kids on the spectrum have. They have trouble describing what they're feeling internally, how their self-concept of gender, how they identify, and so this can be very tricky and challenging. Sometimes you'll see more behavioral signs of this. So I have a patient who I see who is very preoccupied with wearing wigs and wearing girl wigs, and also preoccupied with wearing female clothing. And I'm working with his grandmother and with him to really understand what this is about. But the bottom line is you can see it across different intellectual disability, different intellectual levels. The other challenge in assessment is the challenges with executive function and lack of abstract thinking, which makes it hard for kids on the spectrum to think of gender as a fluid concept. It makes it hard for them to think what the long-term implications could be if they changed their gender. And sometimes they can be very black and white in their thinking. So they might start having romantic interests and think that if a boy is attracted to a girl, they want to be a girl. So again, these are complicated. The ASD presentation makes this more complicated. And I go back to the power of our longitudinal assessment, gathering multiple informants, using multiple methods to tease these things out. In terms of psychosis, psychotic presentations can occur in the autism population. There are overlapping features between psychosis and ASD, including poor reality testing, social cognitive deficits, emotion recognition deficits, poor adaptive functioning, and catatonia. So kids on the spectrum can present with typical psychotic symptoms, negative symptoms, positive symptoms, thought disorder, but they may also present with atypical presentations, more social withdrawal, affective symptoms, the repetitive behaviors may decrease. The one thing I've seen in my clinic is over-focused interests kind of evolving into psychotic presentations. So I actually have seen a couple of cases of kids who are very preoccupied with a certain interest, and then they become delusional around it. So I had a patient who was very preoccupied with CB radios, you know, the communication that truck drivers use. Just collecting the equipment, parents bought him the equipment, parents took him to talk to truck drivers and sit in the truck, just was fascinated about this. But then started developing these ideas that people were talking to him and sending him secret messages through those signals and CB radios, and started thinking that the towers that transmit signals were actually sending, the red light at the top of the tower was actually meant for him. And this started evolving into a psychotic presentation. I also saw a recent presentation of an individual who was very perseverative in their thinking. And somebody told them one day that they were a boy. And so they latched onto it, and they said, I'm a boy. And this became a fixed, firm, absolutely unshakable delusional belief, to the point that their reality testing was altered, and they started getting impaired. So these presentations are very unique, they're very atypical, they're very complicated, they can overlap with autism. It takes time to figure out whether psychosis is present and to tease these symptoms out. And I would be very hesitant to give anybody a diagnosis of schizophrenia until the psychosis is fully evaluated, assessed in relation to other psychiatric symptoms, assessed in a larger context and framework of autism, and until a clinician really understands this profile of symptoms over time. Some common misattributions that I think is really important to remember is that sometimes folks can think that some of the ASD features are really suggestive of psychosis. So perseverative and echolalic statements or pronoun reversals are not suggestive of thought disorder. That's an ASD feature. Self-talk, inappropriate remarks, spontaneous laughing, those are not hallucinations. A person isn't hearing things. Sensory atypicalities are not visual or tactile hallucinations, and idiosyncratic thoughts are not delusions. So this can also be important. It's important to educate parents, teachers, and other caregivers about these distinctions. So moving on to suicidality, we are learning that there are elevated rates of suicidal ideation in individuals on the spectrum. Suicidal thoughts, suicidal behaviors can be associated with depression and anxiety. They can occur in the context of a psychiatric disorder. They can occur in the context of an extreme explosive outburst and an affective storm with frustration and anger and just blurting an impulsive statement. They can sometimes occur because kids want attention or they want to get out of certain situations. So it's important to really think about this broad differential. Risk factors for suicidality: being bullied, being isolated, knowing that you're different, not feeling good about yourself or feeling valued, and again, perhaps maybe to escape an aversive experience or obtain a desired outcome. The challenge in assessing suicidality and working with kids who are suicidal is that the rigid thinking makes it hard for them to shift and develop strategies to cope with the distress. They lack social skills to find other tools to talk about their difficult experiences. They have trouble understanding the impact of their suicidal thoughts on other people if they were to do something, and their language difficulties make it difficult to seek help. Most important, if you have a kid, all children that you see with ASD, it's always important to do a risk assessment at every visit. Okay, last, I'm going to talk about irritability. So this is a transdiagnostic symptom, and by that I mean it's present across every psychiatric disorder. All the disorders that I just covered can present with irritability. It can also be independent of psychiatric disorders and be an affective symptoms that occurs in the context of different life experiences, that it's triggered by different environmental challenges, and can be associated with aggression and self-injury. And sometimes these three go hand in hand: irritability, aggression, and self-injury. Aggression is very common in kids on the spectrum. 68% of kids have been aggressive towards their caregiver, and 49% towards non-caregivers. So it's really important to assess when parents are saying the kid's irritable, child's irritable. You got to assess the impact of aggression and self-injury as well. And irritability, aggression, and self-injury is one of the major reasons for major causes of injury to self and others, isolation, and more restrictive placement, educational and possibly even psychosocial. When assessing irritability, it's very important to look for underlying causes. So look for all the psychiatric disorders that we just discussed. Could one of those conditions be accounting for the irritability? Evaluate for medical illnesses. Pain and discomfort can lead to irritability. Changes in the environment, could that lead to irritability? Inadequate behavioral and communication supports. Maladaptive reinforcement, so again, wanting to get attention, wanting access to tangibles, wanting to escape situations, and ask about bullying and traumatic experiences. When you see a child who's irritable, which oftentimes will be your presenting concern, it's important to first rule out all these other causes. And it's also really important to do a safety assessment for any child who is irritable. Can the child be safely managed at home? Does the parent have resources to manage severe behaviors? In terms of treatment, first and foremost, treat the underlying cause. Medical, psychiatric. If you've got to start advocating for more school services, need to do that. Get the child into speech therapy, get more supports at home. Find out what could be driving this before saying this is emotion dysregulation. I can't find a trigger, an underlying source. First, make sure you go through your differential. If other etiologies cannot be found, or even if they can be, try behavioral interventions first. Have the kids and families work with a psychologist to help with treating the irritability. Consider medications and really think about what medications would I start first. It's easiest to go to the atypical antipsychotics. We have 2, risperidone and aripiprazole, that are FDA approved for kids on the spectrum. But consider trying milder medicines, as Dr. Lohr will talk about. And if you're going to consider atypical antipsychotics, always use caution and an appropriate monitoring plan. So I've covered a lot of psychiatric conditions in this population. There are many resources out there to help you. So the Autism Treatment Network, which is a consortium of about 14 autism centers across the country, has put forth many assessment and treatment guidelines for various conditions, including anxiety, irritability, ADHD, and pharmacologic management as well. These are great tools to help guide you in your practice, in your assessment, and some of these guidelines really just nicely lay out a systematic approach to follow. Autism Speaks also has a medication guide for parents, which reviews all the existing literature on psychiatric conditions and medications for these conditions. The ACAP practice parameters on autism spectrum disorders can be a very useful resource, and also the ACAP practice parameters on intellectual disability. So in summary, as child psychiatrists seeing children on the spectrum, routine screening for psychopathology is critical. Always think about gathering your data from multiple sources across multiple contexts. Tease apart overlapping symptoms and look for atypical presentations. Think about treatable factors, sources that could be triggering or maintaining these psychiatric conditions, and then treat identifiable psychiatric disorders and specific symptoms, initially with behavioral approaches, and then with and psychosocial approaches, and with medications as needed. So thank you all for your attention.
Dr. Vasa, thank you so much for that excellent talk. Mind if we ask you a few questions?
Sure.
How would you talk to parents about the relationship between autism and psychiatric disorders?
I think this can be confusing for parents. How do these two types of disorders connect? And so I think it's important to help them understand that the psychiatric conditions are separate from the autism symptoms. So first, I like to start by reviewing what the autism symptoms are. They relate to difficulties with socialization, communication, restrictive repetitive behaviors, and interests. And then we talk about how conditions such as ADHD and anxiety are separate from those core difficulties. And so those psychiatric conditions are an additional diagnosis added to the autism. We also talk about how psychiatric conditions can intensify the autism symptoms. Mm-hmm. So the presence of ADHD could increase social difficulties in a child with autism, or the presence of anxiety could increase the frequency of repetitive behaviors. And I think it's important for parents to understand these relationships. It will allow them to become better observers and better informants, and that'll help with the diagnostic evaluation.
Absolutely. You talked a little bit about some of the key comorbidities. Could you review some tips again about how you would pick up ADHD in someone with autism?
Yeah. So there are two key take-home points I would suggest when evaluating for ADHD when doing the history. The first pertains to inattention. There are many different causes for inattention in a child with autism, right? A child with autism could appear inattentive if they're focused on their special interest, or if they're preoccupied with some internal thoughts, or if they're in a social situation and they have trouble figuring out what is going on. So it's important to really try to get more details and get more information about the context in which the inattention is occurring before attributing that inattention to a condition such as ADHD, right? The inattention that is characteristic of ADHD is a disorder of sustained sustained attention when engaging in non-preferred tasks. And inattention in ADHD has to be present across multiple contexts, right? Home and school. It can't occur just in one context. So I think it's important for clinicians to take their time when evaluating this particular symptom. In terms of hyperactivity and impulsivity, one key question I really ask is, has the hyperactivity and impulsivity resulted in dangerous behaviors? And has this posed a safety risk? Sometimes the hyperactivity and impulsivity can be quite severe, and so it's very important that we do a risk assessment.
Excellent. What about some key points with ASD and anxiety disorders?
So there are 3 tips I would suggest thinking about when evaluating for anxiety. So the first is to understand the child's developmental level and the child's autism symptoms. So get history on the child's social functioning, language and cognitive functioning, repetitive behaviors, degree of rigidity. Anxiety can aggravate all of these symptoms of autism, so this way there's a baseline, right? In children who are verbal and cognitively able, I would suggest paying particular attention to getting history about social functioning, okay? So kids who are more verbal and cognitively able, it's important to find out, are they interested in social interactions? Are they aware of their disability? And do they have a sense that other kids may like them or not like them? Those kids are at increased risk for social anxiety disorder. The second tip I would suggest is to understand the child's capacity to identify their feelings and express their feelings. So this can be done just by talking to the child, initially asking very simple questions about emotions. You can also talk to the parent about this and get information from them. So I like to ask parents, does your child ever express their feelings to you? Do they come and tell you they're scared? Or do they tell you they worry, right? Once you have a sense about how much information you can get from a child or not, then you know, can I use information from the child, or am I strictly going to rely on parental report and behavioral observations? And then the third tip is to encourage parents to report their observations and not their inferences or interpretations, right? Parents know children the best. But if a parent is worried or they have anxiety, they might be more likely to attribute their child's behaviors to anxiety. So it's best that we guide them in expressing what they are seeing versus what they are interpreting.
And finally, just tips on I think the most common complaint, which is irritability.
Yes.
That is the complaint everyone walks in the door with. My child is irritable.
Yes.
How do you really help tease that apart from the irritability around just their rigidity and other core ASD symptoms?
Right, right. Well, irritability is one of the most common presenting concerns, and the take-home point is rule out the underlying cause. First, see if there is another cause for the irritability versus the child having a reaction to different situations in their environment, right? So other psychiatric conditions such as ADHD, medical conditions such as GI problems like constipation, language difficulties, communication difficulties, insufficient educational supports in the school setting, and family stressors all can be a source of irritability. So it's really important to systematically do a thorough evaluation to find the root cause of irritability before just jumping to medication trials.
Wonderful. Thank you so much for those tips, Dr. Vasa.
My pleasure.
Thank you for joining us.